Usually when you look at a blueprint for a building, the materials just sort of arrive on site. I mean, you get a truckload of steel, a shipment of concrete, and the construction crew just assembles it based on the schematic.
Right, the components already exist in their final physical form before they're ever put together.
Exactly. But, and this is what's so wild, that is the fundamental difference between human engineering and biological development.
Oh, absolutely.
Yeah.
Because in embryology, the blueprint is actively building the materials from scratch. It's synthesizing the steel and the concrete while the foundation is already being poured.
Yeah, that concept of self-assembly is completely front and center in the materials you shared with us today. So welcome everyone to this deep dive into excerpts from the USMLE Step 1 lecture notes for anatomy.
Thanks for having me. It's a great topic.
It really is. And if you are a medical student, a young professional, or just a self-taught learner, you know that what really stands out in these notes isn't just the sheer volume of terminology you have to master. It's the relentless causal logic of the human body.
Yeah, we're looking at a system where every single structure, from the microscopic polarity of an epithelial cell to the vast neural networks of the basal ganglia, is the result of millions of years of architectural problem solving.
Right. So our mission today is to break down these high-yield anatomical concepts for you, focusing heavily on the physiological mechanisms and clinical correlates that make this knowledge actually stick.
Because honestly, rote memorization only gets you so far, whether you're on the boards or in the clinic.
Oh, for sure.
Understanding the underlying mechanism, like why a specific tissue behaves the way it does, or how a developmental anomaly actually maps to a clinical presentation, that's what separates a test taker from an actual diagnostician.
So let's start at the absolute beginning of that developmental timeline, which immediately highlights how complex this gets before the blueprint even has a chance to unfold.
Week 1.
Week 1, exactly. It begins with fertilization in the ampulla of the uterine tube. But the sperm doesn't just arrive and immediately fertilize the secondary oovocyte. There is this mandatory 7-hour waiting period.
Right, capacitation.
Yeah. What is actually happening there?
Well, that waiting period is intensely active at a biochemical level. The sperm has to undergo biochemical conditioning in the female reproductive tract. The plasma membrane of the acrosome, which is the head of the sperm, is essentially loaded with cholesterol and glycoproteins that stabilize it.
Okay, so it's locked down.
Exactly.
Yeah.
And capacitation actively strips those proteins and lipids away.
So it's destabilizing the membrane on purpose.
Yeah, to expose the acrosomal enzymes, which it will eventually need to literally digest its way into the oocyte.
Wow. And once that actually happens, we get a zygote, which divides into a morula, and then fluid develops to form the blastocyst.
Right, and the blastocyst quickly divides its labor. You have the inner cell mass, the embryoblast, which becomes the embryo itself, and then the outer cell mass, the trophoblast, which becomes the placenta.
It reminds me a bit of like a space capsule where the outer hull manages the life support and the inner cargo is the astronaut.
That analogy totally captures the physical separation. But we have to remember the trophoblast is far more aggressive than just a passive hull.
How so?
By the end of week 1, it differentiates into the syncytiotrophoblast, which actively invades the endometrial connective tissue. It is essentially hijacking the mother's endocrine system.
By producing HCG, right, human chorionic gonadotropin.
Exactly. That glycoprotein maintains the corpus luteum, so it continues secreting progesterone, which prevents the uterine lining from shedding.
Which makes HCG the definitive clinical marker for early pregnancy. But the clinical data packed into the quantitative HCG levels is what's really critical for learners here.
Oh, absolutely. The numbers tell a story.
Right. So if a patient presents with abnormally low HCG levels for their gestational age, we're generally looking at a failing pregnancy, like a spontaneous abortion or an ectopic pregnancy where the blastocyst has implanted outside the uterine cavity.
Yeah, frequently right back where fertilization happened, in the ampulla.
But conversely, unusually high levels of HCG point to a completely different set of clinical scenarios, don't they?
They do. It could just indicate a multiple pregnancy like twins.
Yeah.
Or it could be something pathological like a hydatidiform mole.
A molar pregnancy.
Right. In a molar pregnancy, you have this chromosomal anomaly that causes the trophoblast to proliferate wildly without a viable embryo, creating this mass of cystic tissue.
And that tissue just churns out HCG at massive levels.
Massive levels, which is dangerous because it carries a real risk of malignant transformation into choriocarcinoma.
Which is terrifying. And the embryo itself is constantly making these life-altering structural decisions in these early weeks, like Take the indifferent gonad stage around weeks 4 through 7.
That's a fascinating window.
It really is. The embryo develops a urogenital ridge, but it has no specific ovarian or testicular characteristics yet. Now, knowing that female development requires estrogen and the WNT4 gene, it seems like the female pathway is actually the biological default.
It is, yeah.
So there must be a specific genetic override that forcefully diverts that default setting to build male anatomy. I'm assuming this comes entirely down to the Y chromosome.
It does. It comes down to a very specific locus on the short arm of the Y chromosome, the SHRE gene.
The SHRE gene?
Right. That gene acts as the master molecular switch because it encodes the testis-determining factor. Without that factor, the indifferent gonads become ovaries. With it, they become testes.
But flipping the switch is only the first step, right?
Yeah, exactly. The developing testes then have to actively dismantle the female infrastructure that was already preparing to form.
Right, through the Leydig and Sertoli cells.
You got it. The Leydig cells begin secreting testosterone to drive the development of the male reproductive tract from the mesonephric or Wolffian ducts.
Yeah.
But the Sertoli cells have an equally vital destructive job.
They secrete Mullerian inhibiting factor, or MIF.
Yes. The Mullerian ducts, also called the paramesonephric ducts, are the precursors to the female genital tract, like the uterus and fallopian tubes.
So MIF just binds to receptors on those ducts and induces apoptosis.
Exactly. It triggers programmed cell death to actively destroy the female blueprint, ensuring the male pathway is the only one left standing.
So it's active construction and active demolition running concurrently. The embryo is ruthless.
Extremely.
And this massive reorganization continues right into week 3 with gastrulation. The bilaminar disc transforms into the trilaminar disc, establishing our 3 primary germ layers: the ectoderm, the mesoderm, and the endoderm.
And understanding which clinical structures derive from which layer is incredibly high yield for exams.
Absolutely. The clinical relevance here usually comes down to tracing the origin of tumors or understanding congenital malformations. So the ectoderm forms the tissues that interface with the outside world, right?
Right, like the surface epidermis, the lens of the eye, and critically the neuroectoderm, which gives rise to the entire central nervous system and the retina.
And the endoderm forms the innermost linings, the epithelial surfaces of your major internal tubes. So that includes the GI tract, the lower respiratory system, and the parenchyma of the liver and pancreas.
Exactly. And then the mesoderm handles the structural and connective heavy lifting, muscle, bone, cartilage, the cardiovascular system.
But there are a few anatomical curveballs here that trip up a lot of learners. The spleen, for instance.
Oh, the spleen is a classic trick question.
Because it's located in the upper left quadrant of the abdomen, and it's supplied by the celiac trunk, so it seems like it should be an endodermal foregut derivative, but it's actually derived entirely from the mesoderm.
Completely mesodermal. Another crucial distinction involves the adrenal glands. The adrenal cortex is mesoderm-derived, while the adrenal medulla is derived from neural crest cells, which are ectodermal.
Oh, wow. So they have completely different origins.
Yeah, and this is why tumors of the adrenal gland present so differently. A pheochromocytoma in the medulla is fundamentally a neuroendocrine tumor overproducing catecholamines, whereas an adrenocortical carcinoma behaves like a tumor of mesodermal origin, affecting steroid hormone synthesis.
That makes so much sense when you trace it back. So scaling down to how these tissues actually organize themselves at a cellular level, let's look at the epithelial tissues. We know they act as the primary barrier and lining of our organs.
Right, they're highly polarized to pull that off.
Yeah, they maintain a distinct apical surface facing the lumen and a basolateral surface anchored to the basement membrane. But here's the structural paradox to me. Epithelia are completely avascular.
No blood vessels at all.
Right. So if they are doing all this heavy lifting of transport, absorption, and protection, how do they survive and maintain such rigorous internal architecture without a direct vascular supply?
Well, they rely on the underlying connective tissue, which is heavily vascularized.
Okay.
Oxygen and nutrients diffuse out of those capillary beds through the interstitial tissue fluids and just seep across the basement membrane into the epithelial layer.
And how do they keep their specific sides distinct?
The structural integrity of that arrangement is maintained by tight junctions, which literally fence off the apical membrane from the basolateral membrane, keeping the specific transport proteins locked in their correct domains.
And the clinical consequence of that cellular architecture breaking down is severe, isn't it?
Very. When transforming cells begin to lose this polarized organization, when the tight junctions fail and the apical and basolateral proteins start mixing, it's an early index of neoplasticity.
Which physically explains how metastasis begins.
Exactly. When epithelial cells lose their polarity, they also frequently lose their expression of ecadherin, which is a protein that keeps them bound to their neighbors.
So they just let go.
Yeah. This loss of adhesion allows the dysplastic cells to detach from the primary epithelial layer, breach that basement membrane we just talked about, and invade the vascularized connective tissue below.
And from there, they have direct access to the systemic circulation.
Unfortunately, yes.
Man, well, that ties perfectly into gross anatomy, particularly when we start looking at how pathology spreads through the body's regional zones. Like, clinicians don't just view the abdomen as a single cavity, right?
No, not at all. They divide the anterior abdominal wall into a grid of 9 distinct regions using the subcostal, intertubercular, and midclavicular planes.
And the utility of that grid isn't just geographical mapping, it's heavily diagnostic. Because of how visceral and somatic nerves map to the developing embryo, pain refers to very specific zones on that grid based on the stage of the pathology.
Classic appendicitis is the perfect example of this.
Oh yeah, break that down for us.
So early on, the inflammation only irritates the visceral peritoneum, which is innervated by autonomic fibers that correspond to the T10 dermatome.
So the patient feels vague, poorly localized pain right in the center of the grid in the umbilical region.
Right. But as the appendix swells and begins irritating the parietal peritoneum, which is innervated by somatic pain fibers, the pain acutely migrates to the right inguinal region.
Specifically McBurney's point.
Exactly. The pathology hasn't moved, but the neural involvement has escalated from visceral to somatic.
That's brilliant. And we see similar regional complexities in the anterior chest wall with breast tissue, right?
Yes. The mammary gland is supported by the suspensory ligaments of Cooper, which anchor the deep fascia to the dermis of the skin.
And when an invasive ductal carcinoma develops, the desmoplastic response, that fibrous connective tissue growth around the tumor, can physically shorten and retract those Cooper ligaments.
Right, which pulls on the skin.
The clinical presentation is a very specific tethered dimpling of the overlying skin, often described as a peau d'orange or orange peel appearance.
That visual sign is an immediate indicator of structural compromise beneath the surface. But, the more insidious anatomical threat involves the lymphatic drainage of the breast.
Right, because while about 75% of the lymphatic drainage flows laterally into the axillary nodes, the medial quadrant of the breast actually drains inward.
To the peristernal nodes.
Exactly. These nodes run alongside the internal thoracic vessels deep to the sternum, and this creates a terrifying pathway for metastasis because the peristernal lymphatic network communicates across the midline.
Right. This means cancer cells originating in the medial aspect of one breast can travel through this collateral route and seed directly into the opposite breast.
It completely circumvents the standard axillary pathway.
It does. And even when treating the axillary pathway surgically, the dense anatomical crowding presents massive risks. Like during an axillary lymph node dissection for breast cancer, surgeons have to navigate around the lateral thoracic artery.
And running intimately with that artery straight down the superficial surface of the serratus anterior muscle is the long thoracic nerve.
Which originates from the roots of the brachial plexus, C5, C6, and C7.
Right, so if the surgeon inadvertently ligates or damages that nerve while clearing the lymph nodes, the patient loses motor control of the serratus anterior.
Yeah, and the result is very distinct. When they push against a wall, their scapula will visibly protrude backward, the classic wing scapula.
And they'll lose the ability to abduct their arm past 90 degrees.
That surgical complication is actually a perfect segue into the peripheral nervous system.
Yeah, let's talk about the brachial plexus. It's an incredibly intricate network providing motor and sensory innervation to the upper limb. It's often compared to a complex highway, but it's actually much closer to like a massive fiber optic splicing hub.
That's a great way to put it. You have raw data streams, the ventral rami of spinal nerve C5 through T1 leaving the spinal cord. They have to be systematically unbraided and rebraided through a sequence of roots, trunks, divisions, cords, and branches.
Right, to ensure the precise combination of motor and sensory fibers reaches a specific target, like the median nerve feeding the flexors of the hand.
And before that splicing hub even gets fully underway, the primary trunks have to pass through a highly congested anatomical bottleneck in the neck known as the thoracic outlet.
Specifically, the scalene triangle, which is bounded by the anterior scalene muscle, the middle scalene muscle, and the first rib.
Right. The trunks of the brachial plexus and the subclavian artery have to thread the needle right through that triangle.
And if that space is compromised, say, by a cervical rib, which is a developmental anomaly where an extra rib forms above the first rib, or maybe a pancreas tumor growing at the apex of the lung, you develop thoracic outlet syndrome.
Exactly. The structures getting crushed at the bottom of that space are the lower trunk of the brachial plexus, which carries the C8 and T1 fibers, and the subclavian artery.
So clinically, you're looking at a dual system failure.
Yeah. Neurologically, compressing C8 and T1 wipes out the intrinsic muscles of the hand innervated by the ulnar nerve, resulting in a claw hand deformity. Plus, you get sensory loss on the medial aspect of the forearm.
And vascularly, the compressed subclavian artery leads to ischemia in the limb, which you can detect as a diminished or completely absent radial pulse.
It really highlights how vascular and neurological pathways are fundamentally bound by the same fascial constraints.
They really are. And the lower limb shares a similar organizational logic with the lumbosacral plexus, which handles everything from L2 down to S3. What I find particularly elegant about the lower limb innervation is the proximal distal gradient.
Oh, it is incredibly systematic for diagnostic mapping.
Yeah, the higher spinal segments innervate the proximal muscles, and as you trace down the leg, the lower segments take over in a descending sequence.
Right. So if you evaluate the anterior leg, L2 and L3 supply the anterior hip flexors, L3 and L4 supply the anterior knee extensors, and L4 and L5 supply the anterior ankle.
It's just stepping down the leg, and the posterior compartment mirrors that exact descending logic. L4 and L5 handle the posterior hip. L5 and S1 supply the posterior knee flexors, and S1 and S2 supply the posterior ankle.
It's a continuous, overlapping cascade of spinal control. It makes localizing a radiculopathy highly predictable for a clinician.
Tracing all these peripheral wires back to their origin brings us to the command center itself, the brain and spinal cord, which both originate from the embryonic neural tube.
And when the intricate closure of that neural tube fails during the first month of development, the resulting neural tube defects are devastating.
And their clinical severity hinges entirely on the anatomical location of the failure, right?
Absolutely. If the failure occurs at the cranial end, the anterior neuropore, the forebrain fails to develop entirely, resulting in anencephaly. The cranial vault remains open, exposing the neural tissue directly to the amniotic fluid.
And because there is no physical barrier, alpha-fetoprotein, or AFP, leaks out of the fetal circulation in massive quantities.
Right, leading to highly elevated AFP levels in maternal serum and amniotic fluid.
But if the defect occurs caudally along the spine, you get varying degrees of spina bifida.
Yeah, and in its mildest form, spina bifida occulta, the neural tube itself actually closes successfully, but the bony vertebrae simply fail to fuse around it.
The patient might have a small dimple or a tuft of hair over the lower back, but neurologically they are usually completely intact.
And critically, because the neural tube is closed and sealed, there is no leakage. AFP levels remain completely normal.
Okay, but the clinical presentation changes drastically if the defect is large enough that the meninges herniate through the bony defect, creating a meningocele.
Or worse, a myomeningocele, where both the meninges and the spinal cord protrude out into a cystic sac. In an open myomeningocele, that protective barrier is breached again, and you will see those elevated AFP levels.
Got it. Now, assuming development proceeds normally and the anterior neural tube forms the brain, we find the diencephalon deep in the center, largely composed of the thalamus.
Which is the grand central station for sensory input. Almost all sensory data ascending to the cerebral cortex, except for olfaction, must synapse in the thalamus first.
And the spatial organization within the thalamus is highly segregated. Like, for somatosensory input, the ventral posterolateral nucleus, or VPL, receives the spinothalamic tracts and dorsal columns.
Right, carrying sensory information from the body and limbs. Meanwhile, the ventral postromedial nucleus, or VPM, receives the trigeminal pathways, handling sensation from the face.
VPL for body, VPM for face. But the thalamus is integrated into much more than just tactile sensation, isn't it?
Oh, definitely. It plays a critical role in the limbic system, particularly memory, via the dorsomedial nucleus.
And we see the clinical fallout of this in patients with chronic alcoholism who develop Wernicke-Korsakoff syndrome.
Yes. The mechanism there is driven by severe thiamine deficiency. Thiamine is an essential cofactor for several key enzymes in glucose metabolism.
So without it, highly metabolically active brain regions begin to undergo necrosis.
Exactly. And the destruction prominently targets the mammillary bodies and the dorsomedial nucleus of the thalamus.
And because the dorsomedial nucleus is a crucial relay for frontal lobe and limbic memory circuits, its degeneration results in profound anterograde amnesia and confabulation.
Right, where the patient unconsciously fabricates memories to fill the gaps.
It's crazy that this cellular reliance on a single vitamin dictates the structural integrity of human memory.
It really is.
And that kind of profound physiological dependency is everywhere in the brain, especially when we look at how it initiates voluntary movement. Sitting adjacent to the thalamus are the basal ganglia.
Which utilize a staggering mechanism of neurochemical logic.
Yeah, let's break that down. If we look at the direct pathway, which is responsible for promoting and initiating movement, we encounter a circuit that relies entirely on a biological double negative.
Right. The complexity lies in the use of GABA, the primary inhibitory neurotransmitter. Under resting conditions, the internal segment of the globus pallidus, we could just call it the GPI, is constantly firing GABAergic signals into the thalamus.
So it acts as an emergency brake.
Exactly. It suppresses the thalamus, so it cannot excite the outer cortex.
Okay, this sounds like a biological double negative. So to initiate movement, you can't just press a gas pedal. You have to disable the brake.
You have to disable the brake. The cerebral cortex sends an excitatory glutamate signal to the striatum. The striatum then activates its own GABAergic neurons, which project directly onto the GPI.
Okay, wait. So by firing inhibitory GABA at the GPI, the striatum shuts down the GPI's ability to fire its own GABA.
Yes, this is the mechanism of disinhibition. You are literally inhibiting the inhibitor.
Wow.
With the GPI silenced, the thalamus is suddenly released from its suppression. It fires excitatory glutamate up to the motor cortex, stimulating the exact muscle fibers needed for movement.
It's an unbelievably precise cellular feedback loop. The entire architecture of voluntary movement relies on keeping the system completely suppressed until the exact millisecond that the suppression is actively blocked.
Which brings us full circle to the causal logic we started with. The body is constantly employing these intricate mechanisms, whether it's disinhibition in the basal ganglia, loss of polarity in neoplastic epithelia, or the active destruction of the Müllerian ducts during embryology.
It's a vast amount of structural and physiological data. So to tie this all back to the sources you provided, and to give you, the listener, a quick review exercise. If you walk away with just 2 highly testable clinical markers from today's deep dive, remember this. First, despite its abdominal location, which germ layer gives rise to the spleen?
The mesoderm. It is a derivative of the mesoderm, not the endoderm.
Right. And second, when evaluating neural tube defects, what happens to alpha-fetoprotein levels in spina bifida occulta versus anencephaly?
AFP is completely normal in the closed defect of spina bifida occulta, but it's massively elevated when the tube is open to the amniotic fluid, like an encephaly.
Perfect. So as a final thought to mull over today, consider the sheer power of the SPAR gene we discussed earlier.
It's remarkable.
Yeah, that a single locus on the Y chromosome, activating at a precise developmental window, commands the massive structural divergence of human anatomy. It forcefully rewrites the default biological plan.
It does. And given how vast the non-coding regions of our genome are, one has to wonder how many other silent molecular switches are embedded in our embryology. Just retaining the theoretical capability to completely reorganize our physical architecture if they were suddenly turned on.
It makes you look at a building blueprint in a completely different light. Our biological architecture wasn't just handed to us. It actively built the factories, synthesized the materials, and demolished the scaffolding all at the exact same time. Thanks for letting us take this deep dive with you.